Colporrhaphy is a treatment or surgical treatment for vaginal prolapse. It's carried out for women with symptomatic prolapse. It's done usually under a general or a spinal anaesthetic on a short stay basis overnight, or sometimes 2 days. Can be combined with a hysterectomy if there's uterine prolapse, and it can include a repair of the vagina, either the front wall of the vagina if the bladder is dropping down, or the back wall of the vagina if there's posterior vaginal wall prolapse. It is maybe combined with a hysterectomy, or sometimes if the uterus is prolapsing, the patient prefers to preserve the uterus, then something to lift the uterus up as well as support the uterus. So essentially it's for women with symptomatic prolapse, and it's carried out fairly frequently. It's approximately maybe 1 in 12 patients in the UK will have prolapse surgery. Sorry, I need to correct that. So approximately 10%, 12% of women in the UK will have prolapse surgery in their lives. So it's a very common operation for a very common condition. Prolapse usually follows on from childbirth. It's associated with women who've had vaginal births in particular, and women who often have associated bowel, bladder, vaginal and sexual symptoms, many of which can be improved with the treatment of prolapse. It's carried out, the operation itself takes approximately an hour, give or take 15 or 20 minutes, depending on the nature of the prolapse and whether it's 1 or 2 sites in the vagina. And the stitches that are used are usually dissolving, and the recovery, usually patients are in hospital for a day or 2, sometimes even a day case, and back to most normal activities after a couple of weeks. Total recovery can be up to 3 months. That's because the stitches take about 3 months to dissolve completely. The success rates are high, though we do appreciate that in the long term, women sometimes need more than 1 operation. We don't use meshes. I don't use meshes. I never have for vaginal prolapse because I'm aware of the risks of using mesh in this context. We use what we call native tissue repair. So we use stitches and to support and reconstruct the tissues that support the vaginal walls. We would normally consider prolapse surgery for patients who have significant prolapse, so quite often a mild degree of prolapse, or a prolapse that comes down a bit, so the uterus or the vagina comes down a bit. Then patients might be worried about this, but may actually just be seeking reassurance. When a prolapse operation really needs doing is if the prolapse is causing significant symptoms, significant bothersomeness, affecting a patient's quality of life, let's say their bowel, bladder or sexual function, or causing a significant amount of pain or discomfort. If the prolapse has been present for a while and isn't responding to simple interventions, if the patient doesn't wish to use a pessary, for example, she may have tried things like hormonal therapy, vaginal estrogen, which can all help with some of these symptoms. But if those symptoms are persistent and the prolapse is of a moderate or large degree, then I think it's worthwhile discussing the options. And one of the options is a vaginal repair or colporrhaphy, vaginal support, which may or may not include a hysterectomy or supporting the vagina. The main risk of colporrhaphy is the risk of recurrent prolapse. The lifetime risk of prolapse surgery in women is around 12%. So it's a common procedure carried out in the UK. And of all the women who have a prolapse operation, as many as a third might have a second operation. This might mean that they've got a prolapse in a new place, or if they've got a prolapse recurring in the same place. So it can happen. That's why people started looking at meshes to repair prolapse to try and improve the outcome measures, but the meshes themselves caused more problems than perhaps they were worth. And personally, I've not put meshes in for prolapse, but people have, and we're aware that it doesn't work. I think it does mean, however, that if you do have prolapse and considering prolapse surgery, you should really try and see a specialist about it, because it's important to choose the right operation to improve the outcome, to improve the chance of success and reduce the risks. Other risks include things like vaginal infection, and issues with anesthesia and recovery, though because we have good methods of anesthesia, good surgical techniques, then we aim to minimize these risks, and most patients after a prolapse operation will go home the day after surgery. Prolapse surgery is by and large successful. In the long term, as many as 1 in 3 patients may need another operation. So it's not 100% successful, but measuring success in terms of recovery, return to work, return to normal physical activities, then these are the results are generally very good. Looking at bowel, bladder, vaginal and sexual symptoms, these are all generally improved with prolapse surgery and native tissue repair. The recovery from prolapse surgery is often over a course of, let's say, 3 months, but most patients are back to normal activities, including driving, after 2 weeks or so. Colporrhaphy may need to be repeated. My view in relation to prolapse surgery is it's better to do too little than too much. So, for example, we don't want to do excessive amount of surgery, and sometimes, therefore, we accept that we may not repair the front, the back, and the top of the vagina all at the same time. So it's possible that we might say, well, if we have to accept there's a risk of this prolapse coming back, then yes, we may have to discuss that at the time. And the other thing I often say to patients is, if at the time of surgery the prolapse looks less severe than we thought, then maybe we won't do one component of an operation. Or on the other hand, if it's more severe, then we might actually add an extra component, such as a posterior repair at the time of doing an anterior repair. So these things are always discussed with the patient before the operation, and we make a decision together about what's best. Overall, approximately 1 in 3 patients who have a prolapse operation may need another operation in the longer term.